And this is his job talk.
Okay.
So I'll just professor at the University of Texas School of Public Health, and I'm sure you will learn more about his work in this presentation. So thanks, Mike, for coming.
Thanks, Eli, and it's wonderful to see so many friends, indeed old friends, and colleagues here. I always have to be a little bit careful with the talks I give when people are eating to make sure they're not too graphic, but I'm sure in this field you know what I'm facing. So I'm going to talk about essentially nearly 3 decades worth of work in the field of internalized homonegativity. And I'm going to cover, as you see, everything from theory and measurement through to studies in North America, my work in East Africa, our 38-country study in Europe, and then onto for the clinicians, onto the issue of interventions and the models we're developing here. Just need to bear with me. I'm of that age where I've moved from, I guess, from homofocals to bifocals, and I still can't see straight. So first, starting with the definition of internalized homonegativity. As most of you will know, it's the internalized component of external homonegativity, though there's not a close correspondence between these two, and I'm going to explain why. It's often, or was often, called homophobia, and we don't use that term anymore because it's not classically a phobia as we would understand it clinically. It may have some phobic components, but that's not a central aspect of it. I prefer to conceptualize it rather as an issue that fits within the model of minority stress. The idea that stigma, stress, discrimination create stressful social environments for lesbian, gay, bisexual people. I'm leaving the T off because I think there are really very specific components for transgendered people of internalizing negative issues from society. And sometimes we put those letters together when they really shouldn't be together. And Mayer and Dean have defined this as the gay person's direction of negative social attitudes towards the self, leading to a devaluation of the self and poor self-regard. This story really first started way back with Lon Nungesser at Stanford in 1983, where he talked about a dislike of one's own sexual orientation, discomfort associating with people with the same sexual orientation, and willful avoidance of being identified as lesbian, gay, or bisexual by the public. And I call it a moving target because as cultures change, so our measurement of this will change. What we would have called central issues of internalized homonegativity in the 1970s are probably not the issues now because we've come so far with regard to gay marriage as one example. On the other hand, it's a mistake to try and see this just through a North American lens. So where does this fit within a theoretical model? And I think Mayer's minority stress model is the best one. Just to remind you about this, prejudice events lead to chronic vigilance. There may be conflicts between self-perception and others' perception. If the self-perception if there's a conflict between self and other perception, then self-perception can be unstable and vulnerable clinically. Or worse, if there's no conflict, if other perception and self-perception are both negative, it decreases internal conflict, but self-perception is very vulnerable. Individuals with high levels of internalized homonegativity will view themselves from the imagined perspective of others. And note, I say imagined in here, because one of the key issues, actually it was part of my PhD dissertation back in 1980, was looking at individuals' perception of stigma and the actual stigma that they that had occurred to them. And the correlation is actually not high, for reasons I'll go into later. So, as I've already said, there may be a phobic component in it, in that people are phobic, are avoidant of situations to gay people in gay environments. I like to conceptualize it as a sort of psychological autoimmune disease where the psychological body is destroying itself. And through coming out, people develop a healthy identity that incorporates their sexuality. And the early work in this by Eli and by my colleague Vivian Cass in Australia, Vivian working with largely with lesbians, confirms the importance of coming out. Gay people maintain varying degrees of residual anti-gay attitudes integrated into their self-perception. I think there is always going to be, in the societies we're in, some sort of residual damage. John Gonsiorek called this covert internalized homonegativity. This is part of the changing landscape that I mentioned earlier. And covert forms, I think, in North America are the most common, where people tend to appear to accept themselves, yet they still have subtle ways of sabotaging their lifestyles and their existences. And it's this covert aspect which is really becoming the most difficult to measure. And it's been noted that the concept, however, has intuitive appeal to gay men and lesbians. So what would the clinician be noticing with internalized homonegativity? Why is it a problem, not just theoretically? Well, the effects of internalized homonegativity can include self-attacks, where one is putting oneself down, substance abuse or use, eating disorders. For those of you who have worked in the field of anorexia and bulimia with men, you'll know how gay or bisexual men are heavily overrepresented with these eating disorders. Suicidal ideation or acts, HIV risk-taking behaviors, self-blame for HIV infection, difficulties with intimate relationships, and problems in sexual functioning. I probably don't need to stress to this audience. What do we know from community level studies? A recent study by Hatzenbuehler and colleagues looking at data from the alcohol-related conditions study, the epidemiological study, which had a really large N, 34,000. They were able to select out LGB subsample, tiny subsample, but still big enough to do something with. What they found was that lesbian, gay and bisexual people in states with versus without hate crime and employment discrimination were significantly more likely to have generalized anxiety disorder, PTSD, dysthymia, and there was a relationship between LGB status and psychiatric comorbidity only in those negative states. And by negative states, I mean the states with negative histories and employment discrimination. We all know the way the states tend to go in order in the US, you know, with Minnesota at the top and Mississippi at the bottom in more ways than one. It's that sort of discrimination. A second important study was Ryan and colleagues' study looking at family level rejection as a predictor of negative consequences in young adults. And she found that that family rejection was associated with poorer health. And looking at these odds ratios, you can see some of these are pretty enormous, particularly associated with attempted suicide, about 6 times higher level of depression, and more use of illegal drugs, and more likely to have engaged in unprotected sexual intercourse. Interestingly, in this study done in California, Latino men reported the worst negative reactions from their families, which was not an intuitive finding. So we can see clearly also at the individual level there are consequences of rejection. The sources of internalized homonegativity are negative public media, family and school reactions, bullying, for example, peer attitudes and beliefs, an informational deficit, which with the internet we don't so often see now, overt stigma, discrimination and violence, self-devaluation, and expectation of negative reaction, what I call putative social reaction. So what mechanism is likely to be behind these? We've already mentioned the lower sense of self-worth, hiding from associations of any public manifestation of homosexuality, which may be as simple as not wanting to carry condoms or lubricant, which is what we find in my work in East Africa, that they regard as markers of being gay, and therefore people don't want to carry them. So there's a very clear risk possibility here. Wishing to maintain sexual anonymity, which usually comes along with not wanting to discuss sexuality, including condom use, and avoidance of positive models. One of the interesting things I found in my doctoral work in Sweden and Australia was that there was a very low, almost non-existent correlation between the expected or perceived societal reaction and the way people had actually reacted to the individual. And this was worrying because one logically assumes that if there's a high negative societal reaction, then people are going to have more internalized homonegativity. But the reason for this is because those who expect the worst reaction are precisely those who are not going to identify themselves, and therefore they avoid identifying. So at second glance, this is not contradictory. It just means they are just that much more careful and less likely to be in a situation where there's a negative reaction. So just to get that issue out of the way, there is not a clear correspondence. There are lots of intervening variables. There have been a number of scales developed, and the one we use is the one that Simon Rosser and I worked on over 20 years ago, which is a 28-item scale which factored out into 4 dimensions: public identification as gay, perceptions of stigma, social comfort or lack of it with gay men, and a moral or religious dimension. So what did we find with this scale? Well, you know whenever you're talking about work with Simon and he talks about a study of Midwest US homosexual men where that took place. So I'll leave you guessing. And in this study, we examined the relationship between internalized homonegativity and mental health, controlling for degree of homosexuality. And in this study, the odds ratios were showing significant mental health outcomes: major depression, dysthymia, adjustment depression, likelihood of being in therapy, and a fairly robust correlation with sexual health, with a measure of sexual health generally, of the order of nearly 0.4. For those of you who are statisticians, this is the distribution we found in that study, and it looks pretty normal to me, using normal in the statistical sense, which is a great advantage when it comes to one's research statistics. More recently, Newcomb and Mostansky did a meta-analysis of 16 studies, though there were some drawbacks. Only North American studies were included, so the variance was obviously very truncated. They didn't seem to get any large effect sizes. They found a significant effect for year of data collection, which is intuitive because the levels of homonegativity and internalized homonegativity would be expected to go down over time. They argued, I think, inappropriately, that we should abandon the investigation of internalized homonegativity. And on the positive side, that stimulated some useful debate. We pointed out in that debate that using correlation coefficients as a measure of effect size is quite inappropriate. First, because you can't assume that a one standard deviation change in one sample is likely to be equivalent to that in another sample. And second, because as we all know from stats 1, probably day 1, that a correlation coefficient is not a good measure of what's going on. Because, just to give you an example, we all know that if you have a correlation coefficient that looks like that, it's going to approximate 0. Yet there's a very clear relationship between your two variables in terms of what's happening. And so using this as a measure of effect size is assuming that the relationship is linear in some way, and it's just not a good way of conceptualizing complex variables, which we actually don't expect to be linear. So it was clear that we needed to broaden studies beyond North America. Where is homonegativity going to be the highest? Just 3 years ago, the Rolling Stone, not the one that you will know from the US, but a newspaper in Uganda, had this headline, 100 pictures of Uganda's top homos leak. And you can't see it on the slide, but this little yellow piece here says, hang them. And so you can imagine the result of this sort of headline in the press. My friend David Cato was not hanged, but 6 weeks after the headline and his photo appeared in the paper, he was beaten to death with an iron bar. This is not the sort of climate we think about in North America, but in North America, let's face it, we have blinders on very often. My research assistant in Tanzania, Morris Njomba, was tortured to death just 18 months ago in Tanzania for working on the gay project. And I'm not going to tell you about the nature of his torture because you're eating, but it made it very clear that it was because he was gay. And it's not uncommon for gay men to be stoned to death. An actual picture from one of 2 gay men who were caught in the bushes and stoned to death in Nairobi just 2 years ago. So we're talking about harms, and we're talking about issues of sexual health, which, let me make totally clear, can't be divorced from human rights issues. I do not see any issue of sexual health as being separate from human rights. We figured that because my colleagues and I had US passports, we could probably still do some research in Uganda, though I'm not sure I would want to go back to Uganda again. And we used Derek Smolensky's short form, 7-item form of the Ross and Rosser scale, with 216 Ugandan gay and bisexual men. The sample was supposed to be bigger, but a radio station got wind of it. It was an RDS study and broadcast, and before we knew what was happening, there was a mob outside with machetes, and of course we never got anybody else enrolling in the study. This is the climate of internalized homonegativity that we have to deal with. But in this short item, which we used in Uganda, the scale items were those that were culturally and structurally invariant in our US sample, which were invariant across ethnicity, across race, and so we used those items, and they were stable in Uganda as well. We found that internalized homonegativity was significantly and closely associated with, particularly with receptive unprotected anal intercourse. Not a surprise, because men who have sex with men are more likely to think of themselves as being gay if they are receptive, and less likely to think of themselves as being gay if they are primarily insertive. What we used to call the Latin model of homosexuality, but it's very applicable in Sub-Saharan Africa as well, in fact all of Africa. Internalized homonegativity significantly associated with unsafe receptive anal intercourse and unsafe sex while high or drunk, reinforcing the points I made when I was talking about the theory about it leading to unsafe behavior and an environment where people are more likely to be out of it and unable to negotiate use of condoms. This is slightly blurred, or maybe it's just my glasses. It's blurred, thank you, okay. So a further study that I did with Simon was actually looking at the pathways that might lead to the outcome of serodiscordant unprotected anal intercourse, again in a Minnesota sample. Actually no, I take that back. This was in one of our internet samples. So it's a North American sample. And so it seems fairly clear that internalized homonegativity works through other variables, outness as we call it. And if people are less out, they are less likely to serodisclose to secondary partners. And it's going to lead to serodiscordant unprotected anal intercourse. And the second pathway, you'll see both of these have fairly high gammas, was through sexual comfort, which is just reinforcing how important the sexual health model is. We can't keep these things in little boxes. And people who are less sexually comfortable are less likely to be to have high condom self-efficacy. They're not likely to want to talk about or use or deal with condoms, and that again had a very strong pathway into serodiscordant anal intercourse. So I think we are now beginning to see how these pathways operate, and that they're not necessarily direct. And some of Derek Smolensky's work suggests that there is also a strong interaction between being a member or a non-member of a gay organization, which is an interaction with this. You can see the very different odds ratios connected with looking at the joint exposures to well, internalized homonegativity, compulsive sexual behavior, and then the effects of gay organization membership. It's not so illogical. If somebody has a certain level of internalized homonegativity and compulsive sexual behavior, a gay organization is going to provide them with a wide, how do I put this, a wider circle of friends with which to engage in risk behavior. And again, another picture of the path model from Derek's doctoral work. Some of you may well remember Derek. He was in public health here until moving on to Seattle. So let me tell you about the European Men Who Have Sex with Men internet study, which we call Amos for short. I was always telling my colleagues it should have been the Pan-European MSM internet study, because that gave us a much better acronym, but they disagreed with me. Sometimes Middle Europeans have just no sense of humor. So this was a joint project of academic, governmental and NGO partners in the EU. More than 200 local and national LGBT organizations took part. We carried it out in 38 countries and 25 languages, and the data collection took place in summer 2010. The data were collected on the internet. How else could you deal with such a stigmatized population in a study which took place in most of Eastern Europe, as well as Western Russia, Ukraine, and all of the former Soviet countries. It took between 20 and 30 minutes to complete the questionnaire, and we had an IRB from the University of Portsmouth in England. So the methodology was fairly straightforward: random banner advertisements. The N was over 180,000, which has both positives and negatives. It makes Kinsey look a little bit underpowered, doesn't it? Once we'd removed non-qualifying cases and states with less than 100 cases, questionnaires with inconsistent data, the remaining data set was from 32 countries and 174,000, but not all of those had internalized homonegativity data. There was no recompense, and the study was advertised on major European internet sites. You see them listed here, and local LGBT organization sites. It covered a lot of issues beyond internalized homonegativity, particularly HIV risk behaviors, testing, STI histories, and, you know, as we call these demographics, the usual suspects, including discrimination, abuse, violence. So we utilized the 7-item short scale, which I've mentioned before. And I think I don't need to repeat this because I've already said so. So the questions we wanted to face was how do these 32 countries cluster based on abuse, violence and legal score? By legal score I mean on a scale of 1 to 6, where there were 6 possible laws, such as allowing gay marriage, anti-discrimination laws, allowing gays to serve in the military, and so on, where a country could score from 0 to 6, where 6 was the most positive and 0 was the most negative. we were curious to know what variables were associated with internalized homonegativity and risk behaviors, and also to Gini coefficient. For those of you who are not familiar with Gini coefficient, it's a measure of the economic disparity in a country. So a country in which everybody had about the same income would have a Gini score of 0, and a country where one person owned all the money would have a score of 1. And there are some countries where one person almost owns everything. For those of you who are statisticians, with a sample this big, you simply cannot use significance statistics because everything is significant almost. And so we needed to use measures of effect size, listed here, Kramer's phi, Cohen's d, and eta squared, which are not influenced by the size of the sample. And for those of us who were mostly brought up on significance, that really means relearning a lot of one's statistics. So 3 country clusters emerged. No surprise. A liberal one, which was Scandinavia, Northwest Europe, UK and Spain. A second cluster, which was Central Europe and the Mediterranean. And a third one, which was the former Soviet republics. You can see in the map here where the darker countries are the most conservative, the pale colours are the most liberal, and the grey ones are in between. And there were a few surprises. In the first time we were clustering, actually France ended up in the same cluster as Eastern Europe. But we changed the boundary slightly, and France went where we expected it would go, but Turkey came in as well. Turkey down here. I discussed this with some French colleagues, and they said, well, no, that's not surprising, because we have the highest level of Islamic immigration in Europe. And so you would expect more discrimination to be expressed in that sort of environment. So sometimes the surprises are informative. So if we look at internalized homonegativity by country cluster, we can see there's an almost linear relationship, which is the way we would expect. IH was not part of the clustering algorithm. Number of different sexual practices. There is a tendency for those who have least internalized homophobia, or homonegativity rather, to engage in more varied sexual practices, what we would call versatile in some contexts. Not surprising, because if somebody is highly homonegative, they are probably just going to be limited to 1 or 2 practices, do what they need to do, and then move off. Not part of a gay subculture. If we looked at legal discrimination level, we found there was again a largely linear relationship between internalized homonegativity and legal discrimination in the country. So the legal climate seems to have quite an important effect. Gini coefficient was a bit of a surprise. And my interpretation is that in countries which are more economically liberal, these countries also tend to be more socially liberal. You've got the influence of Scandinavian and Northwestern European countries where there is a more equitable distribution of wealth, and less so as you move towards Eastern Europe. We found a clear effect of internalized homonegativity going down as people got older. Not a surprise, because people become more exposed to information and other gay people. But the one that really stood out for me was this one. So this was condom use, and you can see a fairly clear relationship. once we control for a couple of variables. So for people who say, like Newcomb and Mustansky, that internalized homonegativity has no effect on risk behavior, well, here's the answer from a sample of nearly 180,000. And there is a clear impact. So I think that argument has been put to bed's maybe not the expression to use, but dealt with. If we look at a path model as to how this occurs, we find that the best predictors of internalized homonegativity, bear in mind that we have nearly 38 countries with a full data set and 32 with the truncated one. We found that LGB legal climate had an impact. All of these paths are significant. Gini coefficient, and size of the place that people were in. Smaller towns being more associated with internalized homonegativity, and large urban centers with less internalized homonegativity. Again, intuitively, you would expect that. Larger towns have gay communities, and it's easier to be anonymous. HIV testing, the influence of this was high on HIV testing, which showed that for those with high internalized homonegativity, HIV testing was much, much lower. Mainly because it tends to be associated in countries where the epidemic is primarily gay with identifying as gay. If we used a more sophisticated model using structural equation modeling and adding in condom use, again all these paths are significant. We see that the path is through perceived control over risk-taking. People with higher internalized homonegativity feel they have less control over risk-taking. This is probably because they're not able to negotiate. Cast your mind back to that model that I showed you from the internet US sample. And partly through an influencer loop with sexual diversity. And clearly if people are not engaging in unprotected anal intercourse, then there's a less need for condom use. So that loop is not particularly surprising there. But we still get the same major effects at a structural level: size of community, level of legal discrimination, and Gini coefficient. So you might say, well, maybe these effect sizes are not so big. Well, maybe not, but when you're talking about 38 countries in Europe, and you assume that 2% of men, and that's a conservative estimate, have sex with men, even small effect sizes are going to have a major impact on risk behavior. The legislative cost, if we just go backwards, the legislative cost of changing legal discrimination is not high in dollar terms or ruble terms or whatever terms you want to think of. And so we're not talking about necessarily an expensive intervention. We may also be talking about a delayed or a sleeper effect with legislative changes. So having looked at all this, what are the sexual health interventions that are possibilities, just to come to to cut to the chase? Well, internal sources of internalized homonegativity tend to be things like lack of information about non-pathological models of sexuality, particularly homosexuality. A lack of contact with gay subcultures, particularly in Eastern Europe. A lack of counselling services. And And external contributors may be healthcare workers, and I'll talk about more of this in the African context, politicians and organizations and the general public. From the work we're doing in East Africa, which I'm going to finish off with, there's a lack of information about homosexuality at psychiatric and psychological levels, certainly at a human rights level. The religious, frankly, nonsense that you hear, fueled largely by evangelical United States churches who feel they've lost the battle against gay marriage and gay equality in California and the rest of the US. So they're putting a lot of their money into East Africa and West Africa to try and create the most negative possible climate, which does literally lead to people being stoned to death. You saw the picture. There are myths about gender roles and culture and homosexuality and equating it with a gender variant identity. In work with health professionals and the abuse they usually heap on gay or lesbian patients, verbal and clinical abuse, quite frank in fact, is often related to power situations, need to assert control, particularly from nurses. And one of my colleagues in Botswana said, I couldn't take a sexual history from somebody, I'd be fired if I did it. Botswana being one of the most liberal of sub-Saharan African countries, he said we just cannot take that risk. We're to be considered sexual harassment. And this is the level from well-trained physicians. So if you think that sexual health education is not so important, maybe it's not in Minnesota, but let's not forget we're part of the real world as well. And in Africa, this is a burning issue. One of the interventions would be a need for MSM would be a need to enhance self-respect and self-worth. I think the internet would be ideal. Unfortunately, most of our MSM samples in East Africa, only 2% use the internet regularly. So it's not always an alternative. But the internet is tailor-made for this sort of highly stigmatized sample. And so it's a real possibility for reducing pathological stereotypes. We've recently had an NIH-funded study. We've looked at 300 men who have sex with men in Dar es Salaam, which is a city of about 3 million, one of the capitals of Tanzania, and Tanga, which is a provincial city of about 300,000, halfway between Dar es Salaam and Mombasa on the northeast coast. We found, and this is in a paper that was just accepted in British Medical Journal 3 days ago, 30% of the men were HIV seropositive. Not surprising considering they have had no HIV education in this country, because one just doesn't talk about deviant people like this. In fact, some of the men who have sex with men thought that anal intercourse was safer because everybody was talking about how risky heterosexual vaginal intercourse was. This is what misinformation does. 92% of our positives were new detections. And here's some of the shocking information. More than 1 in 5 had rectal gonorrhea or chlamydia, compared with 1/10 of that for urethral. So why is this? Because if they go to an STD clinic, they won't admit that they're gay because of the stigma, and therefore they are treated for urethral discharge, but nobody's checking them rectally. And this is the result. And for those of you who are familiar with the Mwanza and Rakai studies of HIV in Central Africa, you'll know that coexisting rectal and urethral infections are a wonderful predictor of HIV infection, not just because the risk behaviors are the same, but because there will be coexisting lesions which are likely to enhance the transmission, and also immune responses at the site which will activate T cells. Most of them would not go for HIV treatment if they knew they were already positive because of the stigma. They say, we go to the clinic and the nurses say to us, you're gay, you deserve this. This is God's punishment on you for being gay. And so none of them were in antiretroviral therapy treatment. We developed a model, we're actually developing it, which we call the SPEND model, because the usual models don't work, and this is, I think, my last point, since I see Eli looking at his watch, and that's always a warning sign.
You're seeing patients at one.
Okay. So to finish off, you all know with the sexual health model that there are two issues, the cultural issue and talking about sexuality, which are up there in the front of that model. But these issues were so up front that they really are at the front end of any model. How are we going to deal with HIV infection and sexuality in this sort of population in East Africa? And Tanzania is no different from Uganda and Kenya, at least. First, there has to be safe HIV and STI testing and treatment where people are not subject to abuse depending on how they've acquired their STI or their HIV. We need specially trained professionals, sexuality health education. Second, most of the men will go to pharmacies for, at least for STI treatment, because they couldn't go to the clinics because they would be ridiculed in the waiting room by the staff and by other people in the waiting room. It was very difficult for many of them to obtain condoms and lubricants because lubricants are a marker for anal sex. So clearly education of nurses, doctors, pharmacists on sexual health and sexuality is absolutely crucial. There are probably only 5 people in the country who I would feel confident would give even decent counseling on this field. Fourth, navigate patients, because if they go to the clinics they're going to be abused. Therefore they're going to need somebody trained as a nurse, probably, to go to the clinic with them and to help them avoid the fact that people will be telling them they can't get treatment. If it's not overt, like you deserve this, it'll be covert, like, oh, I'm sorry, the doctor didn't come in today, or we're running late and there are no appointments, and those sorts of subtle discrimination. And finally, anti-discrimination and sexuality education at a wider level, because this is where the discrimination comes from. So in this very short time I've been able to give you an introduction as to where the ideas came from and how we slowly started fleshing out those ideas in a research program. First, looking at the pathways that lead from internalized homonegativity through to the negative consequences, and finding that many of these are indirect pathways. How these pathways are contributed to at a structural or societal level from the European study with some interesting and sometimes surprising results, despite the fact that most of these were cross-sectional studies with the obvious limitations on them, through to a high negativity and internalized homonegativity climate in East Africa. And what we're actually finding in dealing with men who have sex with men in East Africa in terms of the clinical, like not just psychological clinical, but the actual medical clinical impact of homonegativity and how men with higher internalized homonegativity are also more likely to put themselves at risk. And I would say we are probably only about halfway through a potential research program, and this is where my next grant, which is, cross fingers, being looked at right now, is headed.